afternoon, everyone. My esteemed colleagues on the dais and distinguished participants. The topic for today's session, and particularly the first line which was there, is very apt for India. Very near yet so very far. And I think the way we have experienced in the state of Gujarat holds the testimony for this particular single line. To start with, we haven't made huge or any success on telemedicine front. And I'm chairing this session on telemedicine. So my presentation will be overall the little emphasis on telemedicine. And I would like to rather learn from others as to how things are moving and how should we go about. So far as Gujarat is concerned, it is considered to be one of the developing or one of the developed states and moving reasonably fast. In Gujarat, we are trying to develop a vision document. To be very frank, I have not seen many vision documents anywhere in the country so far as IT is concerned, and particularly in the health sector. And I think that's the beginning. We are trying to develop enhancing department organization knowledge about IT. I think we are either semi-literate or illiterate. Improving accessibility, affordability and quality of healthcare. Strengthening the governance, increasing overall accountability and efficiency of the system, and ensuring citizen-centric and family-friendly health systems. Over the last decade or so, we have developed a large number of applications. But these are standalone applications, starting from the website to something called a totally IT platform in terms of Mukhyamantri Amrutam Yojana, which we have launched about 3 to 4 months ago. And this slide gives you an idea as to how over the period we have been developing various applications. I would not like to answer this question whether these applications talk to each other or not. Perhaps not. And if at all they talk, they perhaps talk in very derisive fashion. And that's where the real issue is. Just a little idea as to where we are. We developed what is called Gujarat Hospital Management Information System. Perhaps we were one of the leaders way back in 2005. Particularly for big hospitals, teaching hospitals, and district hospitals, sub-district hospitals. But let me be very clear that I don't think we have that kind of IT culture which can take it forward. Perhaps during the session we may, telemedicine is even higher end application. So, but healthcare without IT is unthinkable, according to me. Maybe if we look at what happens after 5 years or 10 years, I'm sure IT will be everywhere or ICT will be everywhere. It is inevitable. So it's always better to accept it and go ahead. But there's something called love and hate relationship in this sector. This is what is my feeling. I'm 16 months old in the health sector with my background in electronics and communication, of course outdated, because it was of 70s. But I find that the relationship between the two doesn't seem to be very, very comfortable. God knows why. Mostly it is more so with the government sector and perhaps more so with the doctors, if they are there. I will not go into the details. This was the objective. Let me not Then we developed, when I came here, I said, okay, let me have some kind of kiosk, which is at least some citizen who is a little educated can get some information, if nothing else, that where is the doctor sitting, which way he has to go up and which way he has to go down, at least that much. So we developed some kind of graphical user interface last year. I have no idea as to how much is being used, because you may say that why is he saying that? Because it's such a complex department where I've got 9 HODs under me, head of departments. And all are developing something or the other. More so it is in the Government of India, where nobody knows how big is the ministry. And again, those silos, or you call them whatever, islands, they may be talking otherwise, but they don't talk business with each other. So it's an island approach. And that's where the real issue is. Then we developed another in 2006, just to give an idea. This is quite useful. Drug Logistics Information and Management System in the year 2006. Now this helped in some kind of decision taking, provided a network and access to the suppliers, also to the regional depots where online information about the stock was available. Now we are expanding it right up to the primary health center level. Today we have about 513 direct demanding officers connected to the network, to the system. And it helps us in ensuring reasonably, I would say, supplies to the health facilities. Now this is something which we are going. Now I'm sure many of you must be, since you must be having technical background, the way IT changes, the way obsolescence is there, I think 2006 and 2002 are totally different. And in the process, perhaps it is not that easy to develop or convert 2006 into the today's needs. But let me give a sort of NIC, when we requested them to extend it to the primary health centers and other rural areas, they were keen and they are developing it. In that sense, we are getting good support from some of the institutions. Since one of the representatives of the NIC is here, I felt that I should communicate this. And in the process, maybe in another couple of months' time, we'll have an extended drug logistics and information management system to ensure that all the supply chain management issues are taken care of. We have also converted our Central Medical Stores organization into a corporation on the Tamil Nadu pattern. Now it is called Gujarat Medical Services Corporation. We are very keen that drugs, we have a free drug supply policy, but we would like it to be branded so that everyone gets it as a matter of right. Today, perhaps they do not know that they have a right. More and more facilities are being added to the application. eMamta is one application which majority of you may be aware. Basically, the mother and child tracking system has been derived from this particular application, which was developed by Gujarat in the year 2010. And now, of course, eMamta is a much bigger, with perhaps having 180 parameters, and whereas MCTS is having about 100 different health indicators and parameters. Now, my feeling is that if you make too big an application, perhaps it becomes very difficult unless you have right kind of IT environment. So we are again looking at it, how to see that this becomes more operational and helps us in decision making. I'll not go into the details. As I said that not much is there to talk about telemedicine, but at the same time I'll come to the extending the way horizons are expanding, and I think we need to talk about that. So this particular program helps the beneficiary, it helps the service provider, it helps the program manager like me, who can have a tap on as to how things are happening. But unless we resolve the what is called is last mile problem, nothing is going to work. And I think we do have a last mile problem like we have it in telecommunication. We had in telecommunication once upon a time. I'll not go into those details. There are many benefits. As I said that healthcare without IT is unthinkable. But we need to really realize that. Another good application which we have done for the last 1 or 2 years is the GPS mobile health unit. We have about 118 of them in rural areas, unreached areas, underserved areas. Now we are able to locate them, track them, guide them, and monitor their performance through GPRS technology. And we are planning to expand this to all the ambulances in the state, in addition to what is happening in the case of 108 emergency ambulances. We have almost 1,000 other ambulances in the state, and we would like this system. Now it's fairly matured, and we are using through our own company called Encode in Gujarat. This is the kind of functional diagram for the tracking system. I will not go into those details. This is the kind of reports we are getting, MIS reports, which helps us in locating and tracking these vehicles. Now this is another scheme which we have introduced, which is on, it is called Health Protection Scheme. It's like insurance scheme, like you have it in Karnataka, Tamil Nadu, even in Andhra, Rajiv Arogyashri and all that. We call it Mukhyamantri Amrutam. It has, and it is entirely on IT platform, using 3-tier security system. Almost 40 lakh BPL families are likely to be benefited. The process has started, everything is online. We have empaneled about 46 hospitals, out of which about 30 are private and remaining 16 government. We treat them as private so far as this particular scheme is concerned, because they have to enter into an MOU with us on the same lines as a private hospital would enter into. This is the kind of advantages we have. Now, like we have used IT platform which was already available for RSBY scheme, and it helped us in, because the beneficiaries are the same, the data was the same, it was UID compliant in that sense of the term. So what we did is we simply took the data from RSBY and started giving them Mukhyamantri Amrutam cards. So this is how the IT can help us in launching the scheme, achieve the speed and do it. It is a web-based online technology. Technology is used right from the day one, and 3-tier structure in terms of QR code, in terms of fingerprint, in terms of mobile, like it is used in any other system. And we expect that, and also deduplication engine also has been incorporated so that duplication can be rather avoided. These are some of the technical features of the scheme. I'll not go into those details. Again, little this, like it is compliant with IT Act 2000 also. Now, digital certificate concept and using that for accountability and non-repudiation purposes. This is what our help desk is today in those empaneled hospitals and also in the Taluka headquarters. Now, another thing which we have done is about Ability Gujarat. We have developed a program for the issuance of the disability certificate to the disabled people, but we have named it as Ability Gujarat. Now, I think there are very few states where this particular scheme or this particular application has been. I think Andhra is one of them. It's a baby which nobody would like to own. And I was in social justice department for 2 years, and actually this disability by rules of business is a social justice and empowerment department, but then they have to depend on the health department. And social justice department is one, let me share, that mostly nobody listens to. And health department was not listening when I was there. So when I took over in the health department, first thing I started doing is that do this at least. Now on an average 2.4% population or 2.5% population is disabled people. Now disabled people, basically we have certain duties towards them. So we thought why not to have some kind of web-based application where a person can register himself, can ask for disability certificate. Of course, if he is illiterate, he can send it by mail or by any other means. Now, as on date, we have about 1.5 lakh registration already on our this thing. Now, earlier camps were being held without any planning and all that. Now you know as to what kind of disabilities are there, where they are, when to go, how to go, and have a very, very targeted approach in this. So this is something, and we are also thinking of extending it by mobile health application, by informing them this thing. These are the processes. I'll not go into those details, but yes, there is the software provides for in disability certificate, which is software based. You just input the data and it will give you a certificate so that you can issue it after due signatures by the competent authority. Benefits, I will not go into it. Now let me come to the present scenario, and I think telemedicine will also meet the same fate if it is done today. This is the scenario. We have so many applications and perhaps more than a dozen, but they don't talk to each other. We have islandic approach. Islands are there. Silos are there. Is this the way forward? Is this the way to carry on? According to me, I am unfortunately by qualification an electronics and communication engineer, so I am really worried about it. I've got 9 HODs, everyone is doing something or the other in the name of IT, and God knows where it will take us. So we thought, let us have a IT vision document. I will be very happy if somebody can share with me somebody who has done it for the health sector, maybe either in India or abroad. I would like to copy it if it is very useful and go ahead with it. But these are the expanding horizons for inclusive care. This is something which is very important. Telemedicine is one of them. Now, almost every state has to take care of the unreached, underserved areas. And let me share with you that in Gujarat, we have 15% tribal population as against 7% in the country, average. We have 7% of scheduled caste population as against 15%. So we are just opposite to the nation. Nation has 15-7, we have 7-15, so far as SC and STs are concerned. And STs are normally, scheduled tribes are normally in hilly areas where normally those are the areas which are underserved and unreached. And that is where telemedicine or any other ICT in health can be a boon or a panacea for. I think we have realized it, but somehow or the other, we are not able to go forward too much. And I think today I have basically come for that purpose, to understand whether there is a way forward. Digitization of record. If you go to any government office, perhaps you will not see the man, but you will see the record, and that too in a very bad condition. So why not to digitize the entire record? Why not to use the smartphones? Why not to use the tablets? Why not to go to the... But then there are issues like costs, connectivity. But Gujarat is one state where connectivity is very good. We don't have those problems which many other states may be failing. But I'll cite now, before I come to this, that we were struggling for telemedicine for the last 1.5 to 2 years. Some isolated efforts have been made by the district administrations, means by district collectors and the district development officer, by launching some telemedicine projects here and there. Maybe 400 numbers which somebody was citing, maybe 5 or 6 are from our state also, but all are defunct. In terms of returns, there is nothing. Somewhere 10 lakh have been invested, somewhere some 20 lakhs have been invested, and maybe the number of beneficiaries you can count on your fingertips. Now this is the state of affairs, but is this the way forward? No. So we thought we will have statewide with, say, about maybe 50, 60 locations where we can have telemedicine. And there was some mistake by our people in terms of RFP. Some correction was made in the main document, but a correction was not made in the annexure, which should have been done. Now, surprisingly, okay, we have certain privileges to be inefficient, but unfortunately the private company also did the same mistake when they filed the RFP. And ultimately there were complaints, and we had to abandon it. 1.5 years of hard work, very hard work, because this was one project which we were wanting to take forward. But 1.5, and naturally in government, once a complaint has been made, which has a substance, which has a criminal angle to it, I don't think anyone in government would like to do it. We had to abandon it, and we have to restart. So I think we need to learn a lesson from that. Are we matured enough, or have we developed skills to take the projects forward? Perhaps not. There was a mistake on our part, but there was perhaps more serious mistake. Had it been pointed out to us, it would have been corrected, but it was not done. So now I was just going through as to what is the situation scenario in other countries. There are some surveys, and the kind of mHealth initiatives in other states are there. But most of them are either toll-free emergency or healthcare centers or mobile telemedicine to some extent, but not many are there. Somewhere they are implemented, somewhere they are partly implemented, and this is the scenario overall. Now, these are the challenges we have. Priority-wise, I think we need to give the higher priority to this. We have little knowledge. I think we have to upgrade our knowledge. We have to be... And policy, as I said, do we have a policy? I don't know. I'll be very happy. We have an IT policy, but do we have a policy for... Then that policy has to be broken down into various sectors. I don't think we have those policies. Cost effectiveness, legal issues. People are afraid of health sector. There is an issue of health hazard and all that. And in the process, we are having problems. I'll not go into those details, but I'm definitely sure that a day will come, maybe in another couple of years, that we'll be using tablets, smartphones, perhaps 200 kilometers somewhere near the jungle where the connectivity is there, and you can provide all the kind of services, at least in terms of this thing, days not very far. And we are very keen to go ahead with that. Now, we have large number of players for eHealth, and I think we need to have a we need to correct our architecture. Today's architecture is, I don't think it has strong legs to stand on. Now that is where I think the industries have to help us, consultants have to help us. Then only things will move forward. Now this is what is my feeling, that this is the way forward, whether it is telemedicine or otherwise, to develop an ICT vision document based on holistic approach. We will be working on that. I request your help. Break the stalemate of love and hate relationship between ICT and healthcare. How do we do that? Use ICT to bridge the gap of healthcare services to unreached and underserved rural areas. Integrate the existing technology. As I said, we have silos and silos and silos. How do we do that? And then I call it benign puncturing. The word I use is, you have to puncture. Now, we have additional director medical education, we have additional director public health, we have additional director medical services. They are onto themselves, they have their own word, they don't talk to each other. So it is the duty of the commissioner or the principal secretary to go on puncturing them. So that, do it benignly, so that they don't know that you have done it. And serve the purpose. Develop a holistic end-to-end IT solution with desired focus on G2G, G2B and G2C. All these are applications, either they are G2G, G2B. But one element is totally getting missed out from the health sector, is that today we do not talk about either the human resource management system or we are concentrating more on health services. But I think without these things will also not go. They complement and supplement the entire effort. And most important is to develop and ensure IT culture by bringing one and all on the same IT platform. This should be the perhaps way forward, and telemedicine in that is a part of it. Telemedicine will grow only when this entire thing grows. Otherwise, telemedicine will become another white elephant, and perhaps it will do harm to itself. Thank you very much.